Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to AMGA's Filibuster in Fine Print, the public policy podcast with everything policy related. I am your host, Chet Speed, and I am with our all-star crew as always. We'll start, we started you last time. Yeah. We'll go to the right.
Hi, everybody. I'm Daryl Drevna, the Senior Director of Regulatory Affairs.
Jamie Miller, Ambassador Goodwill for AMGA.
Alicia Sawyer, Government Relations Assistant.
Lauren Latney, Director of Government Relations, and I'm going to say Department Diva.
HR.
But it's true.
If we all agree,
Daryl and me were like, yeah, that's right.
I know. Right. I got it. If we all agree, it's not HR violation, right? Fantastic.
I mean, look, she shot you when we went the other direction.
I did. Yes, yes.
You felt that, right?
Yeah. Daryl being the one that's like, oh wow.
I felt it.
Yeah.
Oh yeah. No, there was a chill in the air.
It's like, cool.
And because this is our last podcast, we'll talk about this at the end, obviously. We want to thank Mike I for producing. Mike, say hello. Not too close because you're sick.
Thank you all for a great season.
All right.
And, this is Mike I.
Woo! Outstanding. Yay, the best. That probably just blasted.
Yeah.
Sorry about that.
Now he's deaf.
What is it? If we hit 2,000 followers, Mike I face reveal?
Oh.
And he sings a song.
What song?
Of your choosing. Keep it safe for the kids, though.
Rock You Like a Hurricane? No.
It's
It's
very
like-
specific.
That's what I thought. It's hurricane season.
Jeez.
Well, while we discuss the physician fee schedule and the OPPS rule, you can think about what song you want to do, Mike. Does that sound good? Yeah. Outstanding. Perfect. All right. Well, thank you, everybody. So today we are going to talk about two proposed rules, the Medicare physician fee schedule, as well as the outpatient payment policy system. Oh, my Lord, I butchered that one.
Outpatient prospective payments.
There we go. There's our reg lead right there,
Yeah.
Daryl Drevna. So those two rules dropped this week, Daryl, and I think you have a lot to say about it.
I'm very excited.
I'm sure you are. And it is notable that Daryl is the guiding light of this podcast, and he did save the last one of the year for basically him to discuss his work.
Way time
Even
down.
now.
Yeah.
There are two divas on this team.
And he tampered with our mics. I don't think you're going to be able to hear us.
Yeah. Let's just
I'm
pot them
surrounded-
down. And,
I'm surrounded by the two divas on the team. So there we go.
All right.
That's the intro.
Oh, right. So,
That's what it was.
Wow, what a people reader, this guy. Chief salesman. Let's do it.
All right. So, question. Did they do anything with the conversion factor?
Oh, that was
Answer.
supposed to be me. Oh, sorry.
See where it says
Yeah,
Chet?
it says Chet and it's bolded. So no, I will take a step back.
All right, yeah.
So Daryl, what is CMS doing with the conversion factor?
Well, funny you ask, Chet. They're actually doing a couple things. For the first time in forever, they are proposing two separate conversion factors, and it's because of the way the QPP was rolled out all those years ago. So if you are a qualifying practitioner, meaning you're in a qualifying alternative payment model, you're getting a plus up of about 3.83%, and the conversion factor is going to be $33.59 if you're not in a qualifying alternative payment model. So you're a non-QP conversion factor, still an increase, 3.62%, and that works out to $33.42. So on paper, this is an increase, especially over the past couple of years. It's been a decrease in the conversion factor.
Yeah, and this is all sort of connected with the Big Beautiful Bill Act, which we'll have an episode, so you can go back to that one and listen to it in more detail. So there's a one-time 2.5% increase. This was a supposed sweetener on the Senate version of the bill to kind of hopefully smooth some waters with provider groups. But since it's only one time and not what we asked for, little mixed feelings about it, but it is also different. The House version of this bill, it was supposed to be an MEI update, which was like supposed to kind of change the game of how we were looking at payment updates, but no, they just gave us a little temporary bump. And so we'll continue to have to push Congress on this.
Yeah, I'm excited they had that MEI update in the House bill, so a marker is there, so that's something to build on.
Yeah, that's good. And as you mentioned before, we have, frankly, a lot of work.
Yeah.
And we have government funding at the end of September. Then we have a whole list of issues in 26, including conversion factor updates as well as Medicaid cuts. And, our macro value task force. But anyway, Daryl's looking at me because I'm, again, going off script. So I will look at the bolded section that has my name. So, Daryl, we just talked about the fee schedule.
Right.
According to your outline, we'll get to it in a second again, but I'm supposed to go to the outpatient rule right now.
Right.
So can you talk about that?
A little bit, yeah, I can. So just like on the fee schedule side of things, CMS is proposing a positive payment adjustment in reg speak, and it's 2.4% increase for both hospital outpatient departments and ambulatory surgery centers. So again, on paper, it looks like a positive adjustment, but there are some, productivity adjustments, and there's some 340B repayments, so it's really depending on what your case mix is and all that. It might not work out to that 2.4%.
All right, so you might get a little less.
Yeah.
All right, great. Well, let's jump back to the fee schedule.
Okay.
If you don't mind. So it looks like we're getting a positive update for the first time in years. But that may not be exactly the case. Is that right?
That's correct. So what CMS is doing here is they are proposing to include what they're calling an efficiency adjustment, and it's a negative 2.5% cut to, and I love this part, the work RVUs. I got to talk about
RVUs, very good. And we have a happy man to the right.
So a 2.5% efficiency adjustment to non-time-based services, and there are certain exemptions here. So services like E&M, evaluation management, maternity care, behavioral health, telehealth, those are exempt from this. But if you are procedural based, if you're billing procedural based codes, you're going to get hit with a 2.5% cut in this, and it all washes out in the end, according to CMS, because the whole fee schedule is budget neutral. So if you look at it, at the 30,000 foot level, they are shifting payments from proceduralist specialists to primary care. And it's all because of budget neutrality. And I really think, even though on paper you've got this plus up and Congress did this 2.5%, we're still underfunding services. What CMS is reimbursing our providers isn't keeping up with inflation. And part of this has to do with the budget neutrality rules that are, part of the fee schedule.
Yeah, and Congress has been working on this for years. In general, like when we talk about the BBA, they had to cut things for spending. So at CMS, if they change coding and some people get some more money, they have to decrease somewhere else. And the trigger right now is if anything increases the budget by $20 million, they have to do something, make changes. And that started in 1992. It has not been changed since then. So we've supported legislation, Representative Greg Murphy out of North Carolina, to increase that cap from $20 to $55 million. Not saying it's going to change the game, but as Darryl would agree, CMS can't be, helping one and then hurting somebody else in the same. And that's something that it's surprising. The 1992 is kind of like with the GME caps in 1994. There has been no change in this.
Interesting. I was on the Hill in 92 and I was working on that BBA. How interesting. I guess I blew it. Okay. Darryl, what's really interesting in both rules is it looks like CMS is addressing site neutral in a bigger way than they have in the past.
They are. And if you dig into the regulatory text, I expect them to finalize this as written, given the justifications that they've spelled out. Largely, they consider themselves, overpaying for services based on the site of service. And one of the ways they're looking to address this, they want to align payment rates for similar services regardless of setting. And, on the fee schedule side of things, they're reevaluating indirect, physician the RVUs based on site of service. So the work RVUs are going to be half the amounts, whether or not if you're a facility or non-facility based. So if you're facility based, it's going to be half the amount, and that's just going to shift funds to physician offices that are off campus or not part of a system. But like I said before, the real problem here is Medicare is just simply underpaying across the board. CMS also is going to extend site neutral payment to drug administration services in off-campus provider-based departments. So, in the outpatient reg, you've got this provision that's going to clamp down on how much reimbursement's going to go out for these drug administration services. And there are some other things too. I know Alicia's been looking into what CMS is doing with this inpatient only list.
Yeah, so the inpatient only list was originally for procedures Medicare would only cover in inpatient hospital settings. And with advancements in medicine and healthcare, a lot of these procedures are no longer required to be performed in inpatient settings for the patient's need. And so CMS has proposed to begin phasing this list out, and that will begin in 2026. And they have listed 285 musculoskeletal related services that will be removed beginning on January 1st, 2026. And the entirety of the inpatient-only list is 1,731 services. So that's a good chunk. It's a good start for what will come next. And so they'll continue phasing that out in the next 3 years.
Interesting. Okay. And this is one of the CMS proposals. Got it. Okay.
Yep.
Yeah, CMS definitely seems like they're trying to get procedures and out of the outpatient setting into the doctor's office. Is that
correct? Yeah, correct.
I think that reflects that there's a doctor in charge.
I think you could say Dr. Oz has put his stamp on this, and they've ratcheted it up. They tried doing this during the first Trump administration, and now they've brought it back.
Okay.
You could definitely see with everything we've been talking about so far, with this shift to the doctor's office. I think a lot of this has to do with Dr. Oz's experience and your preferences.
Mm-hmm. Okay, fair enough. That sounds, I'm sure that's the case. Jamie, Hill Action on site neutral?
So there's a lot of interest in site neutral because, as you know, AMJ members realize that they're not trying to make the two services providing different places the same price. They're just decreasing it. So there's no going up for one versus the other. So this creates budget savings. If a comprehensive site neutral legislation passed that could potentially cut $120, $150 billion out of the healthcare system, creating savings. So that's something we're monitoring and making sure that the members of Congress understand the impact of patient care and hospital closures. But I think what further complicates this issue now is that Democrats are more interested in it than they used to be, because depending on your site of service, it could dictate what out-of-pocket costs are for the beneficiaries. And so I know we've talked about that in the past as well, too. So both parties are highly interested in this issue.
Interesting. I know Senator Schumer has always sort of kept a hold on site neutral,
yes,
because you look at who he represents. New York City hospitals, that's always important to him. And I know he's always worked on it sort of as a check on these type of things. It'll be interesting to see what happens going forward. Okay, so obviously there are some financial downward pressures from both these rules, especially for our members. Any positives from the rules?
Yeah, there are some positives in the rules, especially related to telehealth. CMS proposes to permanently remove frequency limitations for certain inpatient and nursing facility visits delivered via telehealth. There will be streamlines to service additions to the Medicare telehealth services list. Virtual direct supervision using real-time audio-visual technology would be allowed permanently for many services except those with certain global periods, and teaching physicians must return to in-person supervision for most services in urban settings after 2025. And telehealth remains very popular on the Hill. Mm-hmm. What's not popular is its cost, and many of those extenders are expiring September 30th, and so there will definitely be some action on that in September. We'll see a lot of it moving forward.
Okay. And yeah, as we talked before, we have a busy end of 25 and a busier 26 moving forward. What about ACOs? ACOs created
Yeah.
by AMGA and the ACA.
Right. It wouldn't
14 years
be,
ago, so-
it wouldn't be a fee schedule. That more tweaks to the Medicare Shared Savings Program. And if you look at this rule and then what CMS has said over the past couple of weeks and months, they are interested in sort of ratcheting up the speed to which providers need to take on two-sided or downsided risk. So in this rule, they're going to propose to limit ACOs in upside or one-sided risk only, that basic track, from 5 years, and that's down from 7, starting for new agreements in 2027. So you're going to have less time to get acclimated to these programs. And that's really the big aspect of this rule. Some of the other things in here, they're proposing some flexibilities to try to encourage requirement. Right now, there's a minimum beneficiary threshold of you've got to have 5,000 beneficiaries in. They're proposing a mechanism to allow that to dip below that number during your agreement period, as long as you bring it back up by the end. So that'll add some flexibility to the program for our providers and our members. But the Trump administration is definitely taking a different tack to this next issue. They're eliminating some health equity adjustments. They're characterizing this as a way to simplify scoring. I'm just starting to take a look at this. But one of the reasons to have this equity adjustment in there is to make sure you have a full understanding of what your patient population is, to make sure that the risk adjustment is done properly and all that. And then, there's some add-ons like, there's extreme and uncontrollable policies in these programs. And, this is, if you can't provide care or you can't report properly because of a natural disaster like a hurricane, tornado, that sort of thing, what they're doing here is adding cybersecurity to one of those things. So if you get a cyber attack, and it hinders your ability or hampers your ability to participate or report, there's a way you can be sort of held harmless until you get your computers back up and running.
Great. Appreciate that.
Yeah.
A lot to unpack.
It is. So I've got a lot of reading to do over this summer.
A lot of reading. And I know you have webinars coming up on both these.
I do. August 7th is on the fee schedule, and then August 14th will be on the outpatient rule. Okay. So if you look at our website, you can get registered for that.
And you always have, I think, a minimum of 150 people sign up for your webinars on these rules. So
Very popular.
yeah, you. yeah.
Speaking of divas.
No.
Behavior.
Yes, you are. So, Jamie, any word on the APM bonus issue, which is sort of, it's related to obviously MSSPs and.
Yeah, so as Daryl mentioned, right now the MIPS and APMs, there's 0.25% adjustment and 0.75% adjustment in this 2026 calendar year. That's pretty much the only financial incentive really to go into the APM ACO program, because usually there's the 5% APM bonus. And we've been working, it expired a couple years ago, and we do in year, like kind of with the conversion factor, we do year plus ups and bonuses. And actually last Christmas, there was a 3.5% bonus that we were trying to get for you all, but it got vetoed by Elon Musk. But so what happens now is we're in 2025 performance year, and in 2027, there's no bonus. And we're working now we continue to work with champions in the House and Senate, one of which is the number 2 senator in the Republican Party, Barrasso, to make sure that we get you this incentive, because I think the members of Congress are understanding that the bonus is very necessary so that you can invest back into your people and your culture, because this is not about compensation. This is about investing in models and behavioral health coordination and stuff like that.
All right, good deal. Well, I wish you all luck in that one. So let's see. Again, I'm following Daryl's. Oh dear, I skipped Daryl's outline. Let's see. So CMS is accepting public comments through September 12 for the fee schedule and September 15 for the OPPS. ASC font rules. The fund rules are expected around November 2025 with implementation on January 1 of 2026.
Right.
That's all correct?
It is.
Okay.
It is, yes.
Fabulous. Before we close, any final comments from the group?
Great first season.
Thanks for listening.
Yeah, no, this has been great.
I can't wait to drink coffee from my new mug.
There we go. There we go. Well, as you may have gotten the hint, this is our last podcast for Series 1, as the British would say. Thank you to the best team in DC. Our two divas, Lauren Latney.
I
Daryl
called Diva
Trebnett.
first.
You
so.
did. Oh, so
Diva 1 and Diva 2.
Grand Diva, and then just nice people, Jamie and Alicia. Is that right?
You ever called me nice before?
That's true. So Alicia's
You heard
nice
that?
person.
I'm a nice person.
Yeah, that's
It was on the record.
Yeah.
It's not just
it
my
is.
mom. I think
It is.
Great. Thank you.
It is on the record.
That's
And-
been a ton of fun.
Yeah.
For me.
Yeah.
And thank you also before we look. He's trying to jump in.
Yeah, I did.
Yeah, my guy. Thank you for the help, for producing this.
Showing up.
Yeah, showing up. The
Thank
guy's sick as a dog right now, and he's here, contaminating the whole small room that we're in.
What's your song? What did you choose a song?
Yeah. What?
I was thinking about it, but I was like too focused.
Oh no.
Okay.
Boo.
Surprise for the start of season 2.
Exactly. That's how we start
That's
season
just-
2.
Cliffhanger, right? Cliffhanger.
And I also want to thank Daryl, mentioned earlier, and sort of the guiding force of the podcast. Thank you for everything you've done to get this off the ground and to keep us going. So with that, thank you all from AMGA. Have a great day, and we'll be back in a couple months. Skibbity.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.